Speak today. There's a lot of data in this talk, and I'll try to go through it quickly and give you the highlights. I have no disclosures. So what do we think about age? We talk a lot about octogenarians and nonagenarians undergoing surgery, but we don't talk a lot about patients with premature atherosclerosis. And because of this, I and some of my colleagues decided to use the VQI to look at the outcomes of patients under 55 years old undergoing carotid intervention. This was about 180,000 patients. We included patients undergoing endarterectomy and stenting procedures, and approximately 6 to 7% of each cohort was under 55 years of age. So let's talk about first young patients undergoing endarterectomy. They were different than older patients. They were more likely to be female, African American, and current smokers. In addition, young patients undergoing endarterectomy were more likely to have intervention for symptomatic disease and were more likely to have a non-elective procedure. When we looked at the perioperative outcomes, we found that young patients basically had the same perioperative outcomes as did older patients. There were no clinically meaningful differences. And this remained true whether we looked at asymptomatic patients or symptomatic patients. However, when we looked at what I'm going to call late follow-up, and I will note that this is a mean of only 13 months, younger patients who underwent endarterectomy were significantly more likely to have an ipsilateral neurologic event, any neurologic event, or significant restenosis or occlusion of the operated artery. When we did a logistic regression, we found that young age was significantly predictive of both carotid restenosis or occlusion and late neurologic events. Let's talk now about young patients who undergo stenting procedures. Once again, this population was different than the older patients. Similar to the endarterectomy cohort, they were more likely to be female, African American, symptomatic, and active smokers. Once again, when we looked at peri-procedural outcomes, there were no significant differences between the younger and older age cohort undergoing stenting procedures. But once again, we did find very meaningful differences when we looked at late follow-up. Younger patients who underwent stenting procedures were significantly more likely to have significant restenosis or reintervention. And we defined a combined outcome that we called procedural failure, restenosis, occlusion, or reintervention. And the younger patients were significantly more likely to have this outcome. And this remained true whether we stratified by symptomatic status or whether we looked at TCAR or transfemoral Cas procedures. In logistic regression, young age was significantly predictive of carotid artery in-stent restenosis or occlusion with an odds ratio of 3.5. So in conclusion, younger patients are different than older patients. Peri-procedural outcomes are similar, but young patients are more likely to have restenosis or a problem with their intervention, and aggressive medical management is warranted. So let's talk about sex. The original sin. Among the seminal trials of endarterectomy, neither the original report of NASCET nor the ECST analyzed data by sex. Only the ACAS trial did. However, only 281 women underwent endarterectomy in the ACAS study, and the study was not appropriately powered to look at sex as a determinant of outcome. We all know these results. Endarterectomy reduced the 5-year event rate more in men than in women, and this was primarily due to the increased rate of perioperative complications in female patients in ACAS. When we look at other randomized control trials of asymptomatic patients, including ACST, we find similar results. When we look at symptomatic patients, combined analysis from NASCET and ECST also showed that endarterectomy was less efficacious in women than in men. Although in the CREST trial, we had no significant differences noted. There are hundreds and hundreds of patients regarding the topic of sex and intervention of the carotid in women, non-trial data, and multiple additional studies showing that female sex is actually not a poor predictor of outcome following endarterectomy, and many of these studies had significantly more patients that were women than the randomized control trials. This is a meta-analysis which showed that there was no significant association between sex and CEA outcome. What about stenting in women? Well, subgroup analysis of women in CREST demonstrated a higher peri-procedural stroke rate with transfemoral Cas in comparison to endarterectomy. And again, there are many studies which have shown this. Transfemoral Cas is probably not the best procedure in women. We do have recent data in 2 large studies of TCAR in women, and it seems that from what the data we have, that the results of TCAR in women equal those of men. So in conclusion, I'd like to note that no major set of guidelines recommends different treatment for extracranial carotid artery disease in men and women. And I agree with this, and this is including our recent SVS guidelines. However, I'd like to say that in both women and younger patients, I think that endarterectomy is probably a better choice than transfemoral Cas. Certainly, aggressive medical management and good follow-up is warranted, and women should have eversion endarterectomy or patch angioplasty as opposed to primary closure of the artery. Thank you for your attention.